My declaration slide is as you see it. So liver assist. Well, suffice to say, if there are a lot of machines, we don't quite know which one's right and which one's going to work best for us. I'm going to try and cover some of the techniques which are available in terms of liver support and also offer some sort of personal thoughts about where we might be going in the future, as well as looking back historically over where we've come from. So one of the problems is that liver failure is not a homogeneous disease. And if you look at the papers published on this subject, all of the disease spectrum gets mixed up together. And as such, it's very difficult to define what might be benefit, what is status quo, and what might be potentially harmful. We need to account for that group of patients with acute liver failure and intracranial hypertension, multiple organ failure, this sort of liver here, acetaminophen, subacute liver failure, where these are the little regenerative nodules, or a chronic liver disease with the varices and the ascites and the encephalopathy that we all see, usually for admission on a Friday night, jaundiced and bleeding. The systems that are available to us are the dialysis or cleansing systems, and within that I would put standard renal replacement therapy and suggest to you that that actually is one of the alternative early indications for renal replacement therapy. Albumin dialysis, of which Mars is the best known form, but also single-pass albumin dialysis, the adsorbent systems, Prometheus as well as Mars, and plasma exchange. On top of that then we've got the biological systems, fairly expensive and still very much in trial format. But you've got a dialysis-plasma separation system with hepatocyte exposure, sometimes with other cell types as well. One's got to also consider liver perfusion, the total liver being perfused for the patient. Cell therapy, which I won't really touch on, but certainly in terms of pediatric acute liver failure, injection of hepatocytes into the peritoneum, coated in alginate to protect them from the immune system, or into the portal venous system are effective for metabolic liver failure, and auxiliary transplant, which I also won't cover today. What should the aims of our support system be? Well, what we need to do is separate it into the disease groups. So for the decompensated cirrhotics, we need to provide something which is the equivalent of intermittent hemodialysis, which allows them to maintain stability and possibly go forward to transplantation. That's something that we've not really looked at. All of the studies have looked at those who are already acute on chronic liver failure and decompensated. So that's the second category that we need a system to work for. And in that, we need to be able to reverse the renal failure that these patients get. We need to reverse the encephalopathy, and we need to be able to maintain their nutritional and synthetic function such that they can get forward to transplantation or other therapies. We've then got the critically ill cirrhotic with multiple organ failure on our intensive care units, where we need to reverse the organ failure and get them to a position where they can be transplanted, and then the acute liver failure group, which I've already alluded to, where we need to get stability to either get liver regeneration or to get recovery and transplantation. So what should the systems provide? Well, we need them to provide detoxification. We need them to clear ammonia. Bilirubin is something we seem to want them to clear. Bile acids and possibly other surrogate markers. We want cardiovascular stability. We want to decrease the risks of infection and inflammation. We possibly want it to control portal hypertension, but that's a bit of an ask. We want it to control bleeding. But hey, what do we measure with bleeding? We're inclined to always measure just the INR or the APTR, and we forget, as was alluded to in earlier sessions today, that their protein C and protein S are actually depleted as well, and as such, they are prothrombotic. So we need to look at balanced coagulation measures, thromboelastography, and we need to get an area of regeneration. Liver disease does not have the biomarkers which renal disease has moved forward to collate. So we don't have those easy markers. And certainly the use of indocyanine green, methastatin clearance, sorbitol clearance is not in standard medical practice. So let's just look at a few of these factors. So how about bilirubin? Well, this is a wonderful study by Ludwig Kramer, quite old now, but he just gave some fluid to some patients with decompensated cirrhosis in the ITU and looked at what happened to their bilirubin. And you get a beautiful 20% fall in bilirubin just by fluid loading. So when you look at the data and it suggests that a liver support system decreases your bilirubin, you need to ask yourself, was this fluid? Was it the liver system? And interrogate appropriately. If, by contrast, you give your patient albumin or fresh frozen plasma, you will increase the binding of bilirubin to that albumin, and you will decrease the amount of clearance on your renal replacement therapy and increase the serum bilirubin. And that's seen nicely here in these cohorts of patients from our unit, where you can see a change in bilirubin over a 24-hour period related to infusion of albumin and fresh frozen plasma. This is some data from the Mars system, where you can see that in these standardly measured parameters, you can see a significant decrease in ammonia, bilirubin, bile acids, urea, and creatinine, but maybe similar to that which you see for renal replacement therapy. And this, although it's small numbers, is nice data. It's looking at the comparison of bilirubin falls and indocyanine green clearance in patients with liver graft failure. And you can see that both groups show significant decreases in bilirubin, but it is the indocyanine green clearance which tells you whether the liver function is actually improving. So bilirubin is not a great surrogate marker for liver function, and one needs to consider that. So let me move on now to ammonia, produced through your small and large bowel, metabolized by your liver through the urea cycle, and also through your skeletal muscle. But too often we forget the role of the kidney in this as being really rather significant, excreting some 20% of one's ammonia. And as such, the relationship between the liver and the kidney is pivotal, and the role of standard renal replacement therapy also. This is some data from our unit looking at the clearance of ammonia on standard hemofiltration. And you can see that there is a significant fall, 16% fall of ammonia using standard hemofiltration versus no significant fall for those in the control limb. And indeed, old data shows you clearly that ammonia clearance correlates beautifully with urea clearance, and that has to be good for our patients. This is some old data also from the Charité Institute, Sauer et al., looking at single-pass albumin dialysis. So just creating a 5% albumin concentrate in your dialysis fluid going across a standard filter over a period of 8 hours. And as might be expected, given the water-soluble nature of these products, certainly you can see that hemofiltration clears bile acids very well in terms of hemodiafiltration, and in terms of ammonia clearance, again, hemofiltration is better than SPAD, seems to be better than Mars. So, moving on to the studies themselves. These go back a long way, and these were scary times. There was no monitoring at all in these systems when we were doing charcoal hemoperfusion, and we were just running whole blood across charcoal columns. The learning point here is that the case series all showed significant mortality benefit. And it was only when the randomized controlled trials were published, O'Grady et al., that we saw no benefit to these systems. The bioartificial liver device of Demetriou et al. In Mount Sinai, very elegant, porcine hepatocytes, plasma separation. The case series showed very elegant improvement in cardiovascular status and improvement in neurological status. But in the big randomized controlled trial, there was again, unfortunately, no benefit. The other big series of those of the ELAD study, looking at hepatoblastoma cells, the early studies used probably too little in the way of hepatoblastoma cells. And although they showed some degree of biochemical improvement, they did not show mortality benefit. The new system is much more elegant and is now being trialed in both acute on chronic liver disease and specifically in alcoholic hepatitis. There is an abstract out of China suggesting a mortality benefit in patients with acute hepatitis B decompensation. This is an elegant system. It's plasma separation. The plasma is then run over 4 columns of hepatoblastoma cells grown to confluence. They are maintained with an oxygenator and a continuous supply of glucose. And certainly you need a separate nurse to run this circuit, in addition to the nurse looking after the patient. This is a very old report, back in the 1970s. And no one is suggesting that we are going there again in terms of multiple organ perfusions. But ironically, we are now retrieving livers from potential donors which are not fit for use. They're too fatty, they would result in primary graft non-function. And using ECMO rigs, we can perfuse these livers, and biochemically they appear to improve over time. And they may indeed be suitable in the future for new forms of liver support. I'll just move us on to Mars therapy. It's well known to you all, I'm sure, in the audience, in terms of separate filter and adsorbent column, which is said to absorb bilirubin and other albumin-bound toxins. The case series all show significant benefit, and this was the first of the bigger randomized controlled trials looking at albumin dialysis for hepatic encephalopathy. The responders needed to show improvement in terms of the neurology. There were 70 patients enrolled. There was a significant drop in platelets, but it was seen in both groups, standard of care and Mars. And during follow-up, although it didn't achieve significance, there was a suggestion of more bleeding in the Mars group. And also, again, not significant, but a suggestion of adverse events related to the system in terms of cannula insertion. But Mars did improve resolution of encephalopathy through means that are not quite clear. Ammonia wasn't measured, but there was a more rapid resolution of encephalopathy in this cohort of patients. The other dialysis system is that of Prometheus, where you have plasma separation and the plasma is then run over another adsorbent column. And this very nice study out of Belgium compared standard medical therapy, Mars, and Prometheus. And the systems are clearly different, and we need to learn from this for the future. So the Prometheus system, with plasma separation and adsorption, had much better clearance of bile acids and bilirubin in the hatched lines. But by contrast, the Mars system showed much greater cardiovascular improvement in terms of stroke volume, and also importantly perhaps in terms of renin changes, aldosterone, adrenaline, and noradrenaline levels. So this system rendered more hemodynamic stability, but less clearance of putative mediators. We then move on to the big randomized trials of acute on chronic liver failure. This is for the Mars study, and these patients were very well matched in terms of severity of illness. Unfortunately, however, when you come to intention to treat analysis for this patient group of 185 patients, there was a significant decrease in creatinine in the Mars group and in bilirubin, and some resolution of encephalopathy, but no mortality benefit. Now, is that because the patients were already too sick? Did they all need to be transplanted within a few weeks? Possibly. And maybe this is a system to use more in an outpatient walking wounded system to maintain stability. We need to do these studies. By contrast, the Helios study, the Prometheus separation of plasma and then an adsorbent system, again, there was no significant difference. In acute liver failure, our French colleagues did a very elegant study. It was a multi-center study of acute liver failure, and patients were randomized to either standard of care or Mars therapy. Importantly, they were a group of patients who had all fulfilled transplant criteria. There was a significant number of acetaminophen in this group, and they were slightly unmatched in regard of etiology. But in terms of primary endpoint, 6-month survival, there was no difference between the Mars therapy and the conventional therapy, though the chance of getting a transplant was greater in the Mars group. But it says fantastic things for Eurotransplant, but emphasizes the difficulty in doing these studies, that the median time from listing to transplantation was 16 hours. The median number of treatments was 1. It isn't perhaps surprising, therefore, that we didn't show a mortality benefit in this study. The defining features of mortality were paracetamol etiology was protective and lactate was detrimental, interestingly. There is a new system, my apologies, I've overwritten my slide, that was published as in press at the moment with J Hepatology, and this is a new albumin cleaning option, which has been developed by University College London. This is a porcine study, but it does suggest benefit in terms of mortality, albeit in an animal study of acetaminophen. And importantly, there appears to be greater cardiovascular stability in this study compared to an acute liver failure control group. The control group with no intervention is here in grey. There is improvement in HMGB1, and also there is clear endotoxin clearance on this system. So this might be something that we begin to see coming forward into human pilot studies in the not too distant future. I'd like to move towards the completion of this study, touching on plasma exchange, because I think this is something that we need to incorporate into other extracorporeal circuits for patients with acute and acute on chronic liver failure. The evidence, as published in the Journal of Apheresis some years ago, was large numbers of case series. We're very good at that in liver disease. Not many randomized controlled trials, though. In this case, a large round total of 0. And this suggestion was moderate quality, weak, and we really shouldn't be doing it unless it's an individualized decision. So I'd like to present you some data which is under review by J Hepatology at the moment. It's a randomized controlled trial of 180 patients with acute liver failure, multi-center, mainly driven through Copenhagen. They were well matched in terms of severity, 60% on pressors, 50% on a filter, and 80% ventilated, low incidence, as would be expected for European centers of intracranial hypertension. What is very interesting in this study is there appears to be a mortality benefit for plasma exchange. This is undertaken on 3 days, and it's about a median of 5-liter exchange. The interesting observation is that for those patients who get to transplant, there isn't actually a benefit for offering plasma exchange. Transplant is that benefit. But for those that don't get to transplant, there is a significant improvement in survival in those who are offered plasma exchange. Is that just a severity marker? Well, probably not, because here are those who fulfilled criteria but for psychosocial or medical reasons were not listed. And again, you see that beneficial signal of high-volume plasma exchange. How might it work? It's not quite clear yet, but appears to be affecting innate immunity, clearing damps, but not changing circulating cytokine levels. So it is modulating both monocyte, lymphocyte, and neutrophil function, which is quite fascinating. You need to balance risk-benefit, and in none of these liver systems have we addressed antimicrobial clearance, truly the coagulation issues, and the risks of intravascular hemolysis of, in the bottom here, the circuit, or here, the possible benefit in someone with intravascular hemolysis related to their acute Wilson's disease and clearance of copper on these systems. The last 2 or 3 slides I would just like to present. Sometimes we think that this patient must need a liver support system or a transplant to get better, and this is the problem with the heterogeneous nature of these patients. This is someone with ecstasy-induced acute liver failure. For all the world, we assumed that this heat shock patient was going to need a transplant. This is day 1. You see air throughout the portal system and throughout all of the guts. She was a 21-year-old. She was profoundly unwell. By day 2, it's all resolving. By day 11, It's totally resolved, and she left the ITU well with her own liver at day 21. Similarly, don't always get hung up that it must be the liver that needs support, and this moves into the next presentation. This is a young man who presented with acute liver failure, a lactate of 15, renal failure, elevated bilirubin. The telltale point was the low central venous saturation and a cardiac index when measured of 1 litre per minute per metre squared, with an acute myocarditis, who needed VA ECMO to support his liver by supporting his heart. So in summary, Chairman, ladies and gentlemen, the story for liver disease is not clear. And for me, we need to ensure that we're going down the scientific methodology rather than the creationist methodology. We need to look at the facts and we need to draw appropriate conclusions from them, as opposed to wishing for the world. Similarly, we're probably not on this very rocky bridge of liver support and bridge to transplantation recovery, but we quite haven't got to the very elegant systems that can be seen. And I think it's a great area for future research and collaboration. Thank you for your attention.